A lot for the invitation. I am really sorry I cannot be there with you today, but
Next time.
next time for sure. I don't know your city and your country, and I heard it's it's worth a visit. So next time for sure. Yes, without further delay, you ask me to speak about first pass effect, and uh, and I'm gonna do so. I have a lot of slides. I'll speak for 20 minutes, as many videos that I can show, and maybe you can have some questions. But basically, yeah, first concept is, yeah, that experience is what I got after many years doing this, because many times I didn't get what I wanted. And then second is, I'm going to show many videos here, but take them as, it doesn't mean that what you're going to see in the videos always happen when you do a thrombectomy, but it should open your eyes and think that sometimes these phenomena that we're going to watch can happen, and how can we avoid them, and how can we increase our efficacy in every in every thrombectomy case. So speaking about first pass, this is a concept that was born in 2018, and when we discovered, or we learned that achieving a TK3 is great, but it's even better if we do that at the first pass, because the outcomes, for many reasons, or for some reason, and still unknown reasons, probably, it's better. And then we describe that every additional pass that you fail and then you succeed leads to progressively worse outcome. It's always better to recanalize than not to recanalize, but if we can do so in a single pass, that should be the objective. So therefore, if we think a specific approach, combination of device is gonna suit better the patient, we should adopt it from the first pass, and not think like, okay, I'm gonna try something easier or cheaper, and if it doesn't work, I'm gonna change and switch to the best technique. So just probably try to adopt what you think is best from the beginning. Now, why is it that with 2 or 3 passes, the outcome is not so good as if in one pass, if we achieve the same degree of recanalization? Is it only because it takes a few minutes longer to do 2 or 3 passes? But I don't think it's only about this. And here you can see what happened, how you can go from a TK 0 to a TK 3. You can do that in a single pass, which is what we all want to do. But you can fail in your first pass and in your second pass, and then suddenly go from 0 to 3. And this we call multiple passes, but sudden recanalization. Every time we go from 0 to 3, we call it sudden recanalization. And this is as opposed to these cases in which there are interim stages in which we had a progressive recanalization, and this is a marker of clot friability. Like the clot was broken here at some stages, and you had a progressive recanalization. So anyhow, the big family of sudden recanalization has the first pass effect inside, and this again as opposed to progressive. Now, we took over 400 patients with thrombectomies from our center, and we studied outcomes according to first pass, which is always sudden, or multiple passes sudden recanalization. You can see that the rate of good outcome, MRS-03, is identical here, and if you achieve the same degree but with multiple passes, it's much less. And this is probably, again, because the clot was not fragmented in the first 2 cases here, and it was fragmented, and there are still little pieces that you never achieve to recanalize. Anyway, it's always better to recanalize. Now look, 1, 2, 3, or 4, or 3 passes or more, the rate of good outcome is exactly the same as long as it's sudden. However, most of the sudden recanalizations, the big bulk, occurs within the first pass. And this is why I think we all speak about first pass recanalization, but we should speak about the importance of sudden recanalization, of not breaking the clot, of taking it out as a single piece. But most of the times when this happens, it happens at the first time. And then we can discuss a lot about the techniques, the combination, the adapt, or the stent retriever plus a distal access catheter, balloon catheters. I think each of us may have its preferred technique. I acknowledge that with any technique, you can get good results. I'm just going to show you my point of view here. First, when you do, and you probably saw this video before, but when you perform an aspiration only, you are basically not securing the clot. You are just hoping that this will not happen, but there's nothing much you can do to avoid clot fragmentation of the tail, because you are only securing the head of the clot. And then you wait, as you've seen here, and many times, finally, the clot is ingested, but the tail was not. So in my point of view, I rather, before I start interacting with the clot, I rather secure from tail to head with a stent retriever, and once it's all secure, then I interact and I start aspirating. This video shows everything that can go wrong. We inflate the balloon here in the carotid. We cross here the clot. Many times when we cross the clot, this can happen. We are not aware of it, but this is why we need the smaller profile of the microcatheter. And then as we drag the clot through the tortuosities and through the siphon, we may have the rollout phenomenon. We can lose some fragments, and critical step is the ingestion, where we can have thrombus shaving, because the clot is usually bigger than the catheter. So these three phenomena may induce fragmentation and leading to partial recanalization. Now, many times, once we deployed the stent, we like to perform a contrast injection, right? And I think we should think twice or three times why we do that. Is it really necessary? Because many times, and this is again exaggerated, but it certainly can happen, when you inject your contrast here, you can just wash away the clots, as you just seen in the video. And that leads to this little fragmentation here that we probably pushed a piece of the clot here while we inject the contrast. So we did in our lab some testing, also here exaggerating. We had this initial clot location with the stent retriever, and we pushed really hard the contrast, and clot went all around, even in non-affected territories. Now we measured, and here, and I apologize because the legends are not showing, but this is the fragments that we get at the output of the circuit when we push the contrast, as I show you. And the less amount of fragments is number 7. This is where we didn't do the contrast injection, and the grading here you can see is because those was very fast injection and very near the clot. And when you do a slow injection from the carotid, so from far away from the clot, giving the possibility to the pressure that you generate to buffer across the different open branches, you reduce the chances and the pressure on the clot and the fragmentation. So if you really need to perform a contrast injection, just do it very gentle, very slow, and from below, from the carotid artery, ideally from extracranially, so there are branches that can buffer the pressures that you're generating. Now, this is also a very famous video that shows another thing that can happen if you do not use distal access catheters. Here, the vector of forces that is applied will generate this in this direction, and you may harm by causing what you call avulsion damage from perforators here. And the next video shows what happened. In fact, if you have your distal access catheter, and you pull your stent retriever, the vector of forces at this stage is going to go this way. It's modified by the duct, and you're not having this risk of avulsion damage, right? This is first thing why these distal access catheters, or now we call them aspirating catheters, were invented initially, because can modulate the vector of forces that we apply with the stent retriever. Now, when we do the maneuver, the thrombectomy maneuver, basically there are different ways to do that. One of the initial ways was what we call solumbra. It's aspirating and ingesting the clot here at the site of the occlusion. This would be the M1, terminal ICA M1 and the two M2 branches here. And if you do the clot ingestion here on site, especially if the clot is soft, this is the best situation where all these little fragments, this clot is very fragmentable, but you avoid embolization because it basically you ingest it here and it's very easy to swallow it by the aspirating catheter. Now, if we do the same solumbra but with a stiff clot, now the stiff clot is also generally bigger than the distal access catheter, and here we see how just the stent is slipping and is not fully ingesting the clot, because this is a hard clot that would not be totally ingested in the smaller diameter. So it's very important to use as big as possible, but always this distal access catheter is going to be smaller than your base catheter. And if you decide to do, in contrast, what we call safe technique, the ingestion of the clot will be, in fact, oops, that was very fast. I go again here. We start pulling, and the ingestion of the clot will be done at this level of the base catheter, which is bigger. And that was a soft clot that is integrated in the stent. But if we do that with a stiff clot, the clot is not ingested by the duct. It's only held between the stent and the duct and the negative pressure. And you see it's always outside the duct. And you slowly pull it. And the ingestion, in fact, of this big clot is going to happen only in this larger catheter. This is why I'm showing here a larger green catheter, right? Obviously, safe can also go wrong, but for different. So see here, you see very well how you pinch the clot, but it can go wrong for other reasons, right? Here you are going to see how at some point, yeah, there is a little distal embolization. What happened in this case? If you look slowly at the video, this is how you start. You pinch your clot here. You have what we call your safety net, or the stent that will grab pieces of the clot. So ideally, the safe technique is good for clots that are not fragmentable. You just pinch them from one end and you bring them to the distal, to the catheter, to base catheter here. In this case, what happened, you see, initially we had all this safety net, and by the time we are here, there is only very limited length, because many times the distal access elongates, the stent wire does not elongate, and as we are pulling, the stent comes progressively inside the duct, and that would create the ingestion here, and you might lose some fragments, as you can see here. On top of that, we are holding some clot. You can see here some red inside. We are holding clot here, so we are avoiding the negative pressure to generate reversal of flow. This reversal of flow, because the negative pressure is stopped here by the clot that is held by the stent here. So this guy here is not protected by reversal of flow, and we lost it. And this is what happened in this case. We wanted to do the safe technique, but accidentally the stent came inside the duct while we were pulling, and we had all these little fragments that you see here. The only thing we could do is to inject some tirofiban, and some of these occlusions improved, but many did not. When this happens, and you have all these multiple occlusions, you are in a bad shape, and there's not much. You can try to do regional fibrinolysis. This is what we did. The final CT scan does not look so bad. So in our model, we decided to measure here, and I'm going to show you with different techniques and different clots, the amount of emboli that was generated and retained in this outflow filter. So we randomized clots after embolizing them to save versus solumbra, and we captured in this filter here, and then we process an image, we take a picture, we process it, and we have an algorithm that gives us the number of clots and the size of clots. So when you use soft clots, you can see that the rate of first pass recanalization is higher with Solombra. Then if we go to stiffer clots, it gets more equal. And I believe that if the clot was even stiffer, the first pass recanalization would be even better with SAFE and less good with Solombra. Again, because the ingestion, the final ingestion, when you do SAFE, occurs in the guiding catheter, in the base catheter, which is larger. And this is the reason. And it does not fragmentate if it's stiff while you pull it unprotected. So if we were to know the nature of the clot before starting, we could very well decide which is the best technique. Again, here you see with the emboli count that we had was lower always when we did the Solombra technique with soft clots. So this is the ideal positioning that I like. This is a very soft clot again. I place as much stent as possible beyond the clot. And here we start doing the procedure. Now we will start aspirating here. And this is very fragmentable. Think what would happen if you do SAVE. You're going to see it's very fragmentable. And this little guy here, finally, we're going to aspirate it. I'm sure that if we pull this all together and we do the SAVE technique, some of these fragments could have been lost, right? Again, we don't know the nature of the clot. So in my opinion or in my practice, I think most of the clots might be soft. So I start my initial pass. My first pass is like doing the Solombra here. If the clot is stiff, I will lose it doing that. And then my second pass, I will do SAFE. Anyway, when we have to consider very well the angle when we make decisions. Also, very flat angles are very good for aspiration only. But as the angle gets sharper and closer to 90 degrees, the efficacy of aspiration alone is lower. So this is very unfavorable for aspiration alone. This is very favorable for aspiration alone. The bad thing is that when you have the clot, you don't know where the anatomy is going to go, and therefore you cannot anticipate and predict. So with ADAPT, you cannot predict, and this is what happened. The only thing you can do when you are pushing your aspiration catheter is that you aspirate and you hope that it will get in touch with the clot. But here, as you see, the only thing we can do is push, and we will never get it because it's not in a good angle. Also, we need to be aware of this. Sorry about the noise here. Collapsing of the vessel. When you aspirate inside of a MCA of the rabbit or human, you get collapse. Here you see the collapse of the artery. So if your clot is far away, if you are kissing the clot before you start aspiration, that's fantastic. If your clot is a few millimeters away, you will not have any influence because you are just aspirating the vessel wall. So you need to know exactly the timing, and you need to be very precise when you start your aspiration, when you do ADAPT alone. Here you can see how also MCAs, and there's a flow diverter in the artery, and we aspirate, and there was a thrombosis here. They tried to aspirate the thrombus, and they realized that you can collapse the MCA by aspirating. So it happens when you have a clot also here, and if you are not aspirating exactly at the exact moment, you might not touch the clot, right? In the other hand, when you use a stent retriever, the stent is kind of holding in place the artery. There is some degree of collapse here, but not complete degree. And then it's not so critical exactly when you start your aspiration, because you can still bring in or pull or push your advance your catheter, and you don't need to be so precise. I will stop in a couple of minutes, but where should we do ingestion? In the middle of the segment, next to a curve, after the curve. So as we saw before with aspiration only, when you use a stent retriever, the same can happen. The stent is pushing the clot away, and our aspiration catheter is coming this way. So, in fact, this is what is happening. The stent is slipping here, and here you can see better how we are not having contact of the clot. And these curves are very important. Basically, most or all the stents, at some degree, they have this collapse here when you pull the stent. The tension makes the stent to collapse. And think, if you have clot here, when you bring it to this point, it will just be free and the stent will slip away, and the clot will stay here. Here I'm showing you this curve here. We are pulling the stent, and now the stent is going to be pulled. And you see here, there's no stent. All the stent is collapsed here. And only at the very last moment, we bring in the stent. And I'm going to explain you why. Only in the last centimeter of the stent. And this is why, because while the stent was here, there was a lot of tension and collapse here. Once the tip of the stent comes here, there's no more tension and the stent's open. And at this time, now the stent is really effective because it's grabbing the clot, but only this last centimeter or this last very few millimeters. And this is why at the very end, this last portion of the stent made the clot come in. So in these cases, we can think about two consecutive stents. So the first stent will bring initially the clot, and a second stent deployed further away can do the rest of the job, as I'm going to show you in the next video. Here we have two stents, one ends here, one ends here, and then we initially pull one, and because there's not a lot of tension, this first one is going to be already effective because there was not a lot of tension, the stent was not really far away. And then we have, as a safety net, a second stent that might help finishing the job. So yeah, again, probably it's not necessary good to have a long segment of the stent beyond the clot. There's going to be a lot of tension when you pull, and you might have a lot of collapse here of the stent. So probably it's enough to have just a few millimeters and not a lot of tension, as I can see here. And always, when you ingest it with a stent, pull the duct under maximal negative pressure, because there might be some fragments. Many times, like here, we do our thrombectomy technique, we aspirate, we pull the stent, and then we have the stent outside and we forget and we just pull the duct and we can lose a little fragment. So make sure that you pull your duct when you have you might have a piece of clot at the tip of the duct and under maximal negative pressure. I have another couple of slides. Okay, I'll be 2 or 3 minutes late, sorry. But very important, when you cross the clot, the minimum diameter of the microcatheter, because many times also I thought it's very safe to cross only with the microcatheter, and I was suggesting that for many times, just to pull away the wire and to cross the clot with the microcatheter. But it's like you are pushing some dull knife. Here, look, I did that. I have the microcatheter here. I push it through the clot, and look at this little guy. The microcatheter broke the clot, and now I'm gonna lose this little fragment. So maybe if I were to use initially the wire, which is sharper, I would not create these fragmentations with the microcatheter. So very, very progressive diameter enlargement when you cross the clot. And in fact, this can also happen when you navigate, when you snake your distal access catheter. This can happen. You don't have control many times. I'm going to play it again. But here you see I'm pushing the duct, and many times I have this tension release that just hit the clot suddenly. Like here, I try to be very cautious, but yeah, sometimes you cannot control the release of the duct, and it hits the clot. And unfortunately, yeah, I hit the clot, and I had a lot of little fragments that I probably generated by hitting the clot. And yeah, I'm gonna skip this because it's the time, and I leave it here. I'll stop my presentation, and maybe we'll have time for a couple of questions, or not. I hope so.
Marc, thank you.
Thank you.
This is Vlado. I have one question. What do you think? What do you feel about some guys now starting to use double stent retriever technique for the first pass, and they are saying that they are having great results?
Well, I am one of these guys, actually. I think so. You know, for a while, we have been saying that double stent retriever can be a bailout option, right? A rescue option when you fail 1, 2, 3 times and you don't get a clot. And it worked as a rescue technique. So theoretically, if it works better as a rescue technique, why not to use it in your first pass? Well, yes, it's more expensive, of course, but it can also generate more damage to the endothelium. But we did a study in pigs, in renal arteries of pigs, and we concluded that the damage on the endothelium of 2 stent retrievers equals 1.4 times the damage of a single stent. So meaning that if you do 2 passes with 1 stent, it's worse than to do 1 pass with 2 stents, right? And it seems to be very safe. So we initiated a randomized trial that we called twin to win, and now we are randomizing patients with proximal occlusions in bifurcations, terminal carotid, top of the basilar, terminal distal M1, and we randomize them to first pass with 1 stent or 2 stents. And so far we have 60 patients. We'll have the results in the next months. We'll have the results of the trial, but I think it can increase the number of first pass recanalization.
Thank you.
Marc is Ivan. What do you think? Where will be the next frontier? Where will these technical advancements lead us in the near future?
Yeah, well, so we could think that we have 90% rates of recanalization, 91, 95%. But still, if you look at the rate of first pass recanalization, best cases are showing 50%. So we need the tools that lead us to 90% rates of first pass recanalization, and then we need to know beforehand or very, very early which patients have an underlying ICAD. We need to know the clot composition to tailor the technique that we're going to use, the nature of the clot. Is this an underlying ICAD? So we can do an early angioplasty and stenting. And of course, we need specific devices for distal occlusions. There are more and more devices specific for distal occlusions, but I still think that we can go or create safer devices for distal occlusion. So we still have a lot of fun to discover, fun things and tools and ways to practice to discover. A lot of research we can still do a lot of research in the world of thrombectomy.
Yeah, Vlado, again, balloon guide or not?
Okay, the answer is if you have a balloon guide, a good balloon guide that navigates well, why not? But still, I think most of the balloon guides that we have, you cannot place them very high. You have to leave them quite low, or many times you cannot navigate them. So that is a problem. The day we will have balloon guides that have great navigability, I will be convinced that it makes a lot of sense. But you should be able to consistently deliver them to the terminal ICA.
Any more questions? Marc, thank you very much for your effort, and have a good time in Barcelona with your family, and see you probably next year here if you like, or somewhere else.
Sure. Have a great congress, and I can see some of my friends here or in the panel. Hello to everyone, and enjoy the rest of the conference. Bye bye.
Thank you, Marc.